I'm Arnold Seto from the Long Beach VA. My co-moderator here is Mauricio Cohen from University of Miami. And we have a distinguished panel of Farshad Forouzandeh from CASE, Anand Prasad from Texas, Sheila Sahni, now from Hackensack, and Yader Sandoval from the Mayo Clinic. So we're just going to go through some interesting cases with your presentations, and we'll ask for commentary from the entire audience. Our first case then is Iyad Azzam. Thank you very much.
So Iyad Azzam was my fellow, and I hope he will not embarrass me.
Yeah, no pressure.
To make fun of him. You can do anything you want.
Yeah.
Yep. Well, thanks everyone. I practice in Nebraska. So I'm presenting a patient with retrograde PCI of chronic total occlusion of the right coronary artery using NAV groove of the left circumflex artery. So this is an 83-year-old gentleman with hypertension, diabetes, and dyslipidemia. He's known to have coronary artery disease. He presented several months ago with shortness of breath and some EKG changes. So he was taken to the Cath lab at that time and was found to have severe LAD disease, bifurcation disease, diag, and chronic total occlusion of the right coronary artery. He elected not to go for surgery. That time we asked a surgeon to come and speak with him and his family. They declined, and he isn't really the best. He wasn't really the best candidate for it. So he underwent successful intervention of the LAD and diagonal artery at that time. Then there was an attempt at intervention of the right coronary artery that failed. We optimized his medications. He continued to complain of shortness of breath. We did a nuclear stress test that showed significant ischemia in the infralateral and inferior walls of large extent. So he was brought again for another attempt at intervention of chronic total occlusion of the right coronary artery. This is his anatomy. On the right side, you see an ambiguous plaque in the mid-RCA, and then it reconstitutes. Let me just play again. At the middle segment where there is NAV, an acute marginal artery, then there is another CTO distally. This is the left system showing patent stents in the LAD and diagonal arteries with left to right collaterals. Unfortunately, there were no great septals to support the right system. There is NAV groove branch right here that fed the right PLV, which in turn supports the other branches, including the PDA. So we started with an anterograde approach. We had 7 French system in both femoral arteries. Dr. Cohen would not like it. He probably wanted by radials. Yeah, at least one radial. Yep. So we used Pilot 200. We were able to cross the more proximal occlusion right here, and but the whole system kept selecting this acute marginal. So I advanced a balloon trying to obstruct it, and then tried with a progress wire and Confianza Pro 12 to cross into the distal RCA, but this didn't work. So we advanced Pilot 50 wire supported with a Corsair. In the circumflex, we selected the AV groove branch and were able to advance both into the AV groove, then branch, then the PLV, and Corsair was not able to go any further here with the beyond this point. Pilot 50, we were able to advance it all the way up retrogradely into the aorta. I tried to snare it. At that time, I had a 7 French AL guide catheter in the RCA. Tried to snare, didn't work, so I pulled it out and used a 7 French short JR4 so that it sits more coaxial. I was able to wire the guiding catheter, and then I snared the wire in the guide and pulled it out. After that, the procedure went really smooth. We serially dilated the whole segments of the right coronary artery. Then we were able to deploy 4 drug-eluting stents without losing any side branch with TIMI-3 flow. And we didn't jail any of the acute marginals or several branches. As you can see, all the PLVs, the PDA with TIMI-3 flow. There is still an 85% ostial right PDA, but I elected to stop there. There was TIMI-3 flow. This is a left angiogram that shows no complication in that circ system, and a right angiogram showing 0% residual and TIMI-3 flow in all the branches. This was my first, actually, retrograde intervention a few years ago.
All right, very good, very good. You know, they rank CTO operators on 4 levels, and so the 4th level and the final level is using epicardial collateral. And I can't say I've done that yet, and I commend you for this great result. A couple of key things are when you're doing the retrograde approach is, of course, to always, when you're removing the wire, make sure you have the catheter in, otherwise you'll shear it, right?
Exactly. So 2 things, actually. I'll show you one of the pictures here that you're absolutely right. If there is a lot of pressure, you know, on either side, you actually compress the heart, and when you completely pull out the wire, actually I re-advanced Corsair back and pulled the wire. Yeah, without that, you're absolutely right. You will cause, or some might cause complications.
Right, you actually might shear the artery on the way out. So that's the last thing you want when you have a successful.
Absolutely.
So an alternative technique to the snaring of the wire is just to advance the wire into the guiding catheter and then wire the tip of a Corsair or microcatheter. We've done that a few times. I mean, that's something, I think it's called the rendezvous technique. So that's another possibility. Now, would you use IVUS or do additional imaging in this case? Think about that.
I didn't think, honestly, at that time. I totally agree now. You know, the more I'm doing CTOs, absolutely, I totally agree. I mean, one will be really amazed how big the artery is compared to what it looks, actually. The Corsair thing, I wanted to advance it all the way up to the right guide, but as I mentioned, you know, it got stuck at the distal to mid RCA. We had real hard time trying to snare that wire.
Very nice case.
Thank you.
What's your approach? Which is your first go-to wire, second wire for wiring epicardiols? I think you mentioned pilot, but I wasn't sure whether that's your
True. I like Cheyenne wire. I like Fielder FC, Pilot 50. You know, again, you know, when some have more experience, you try now to change your selection of wires. Now my go-to wire for retrogrades is Shine, then Fielder FC, Shine Blue. I rarely now use Pilot 50 for these cases.
In this one, you cross it with Pilot 50?
Pilot 50, yep.
I think the case really highlights the classic approach to an ambiguous proximal cath really should go with a retrograde approach, and the progress TTO score really has shown that in the registry data. Next case.
Thank you.
Yeah, I want to actually amend the same thing that Mauricio was mentioning about intravascular imaging. There's a recent paper from Manus Berlakis showing that how rarely actually it is used in CTO situations and how often it changes the stent sizing.
Absolutely.
Especially actually your LADS and also your bifurcation, I'm a little bit worried it might be a little underexpanded. I would say, you know, especially Sparks LAD, you do a nice job in CTO, but without an IVUS, if not OCT, to just make sure this is well expanded.
True. You know, with these long cases, probably, you know, in the beginning, one will be like, okay, well, it's a successful CTO. Let me get out before any whether complication or radiation time or contrast. But the more one does, the more one acknowledges that actually it helps a lot.
So one remark, again, it's a great case, and you are busy in private practice, so
Yeah.
how did you manage to take all the time? Did you bring a proctor? You don't get to do all the cases. I mean, you're just cranking through cases
Yeah.
there in Nebraska. So
Right.
what was your setup in a busy private practice to
Yeah, so
set the time apart and do a case like this?
sure. So you're absolutely right, Dr. Cohen. We're still in contact. He knows a lot about my practice. You're right. It's an extremely busy practice. More than 20,000 work RVUs a year, with a lot of outreach clinics and more than 600 to 650 diagnostics and more than 380 interventions a year. But for these CTOs, actually, I used the piece of advice I got from Dr. Brelakis when he came and proctored me in Nebraska. For these cases, you're not on call, you don't have a clinic, you can't be bothered by someone, all right, well, someone called you for something. My staff knows that I don't want to be interrupted. I don't schedule more than 2 cases that day. I'm not in clinic, I'm not on call, and I don't do rounds or consults. Yep.
Very good. As a final comment, just a point of clarification, this is not your first retrograde case, or is it? Is it retrograde epicardial or retrograde septal? Have you not?
It was first successful retrograde ever.
Okay.
Yep.
So very good. Yeah.
Thanks.
Many people would recommend starting with a septal, but clearly you didn't have that option.
Yep. Yeah. We tried. We looked at the previous 2 Caths, trying to find like something. I wanted absolutely to avoid starting with an epicardial, but we couldn't. And there was really no other option. The patient was already on 4 anti-ischemics. He turned down surgery. We tried an anterograde, and during this procedure, another anterograde. So.
Well, clearly you got good training from Miami. So.
Yeah.
So our next case is.
Thank you.
Thank you. Dr. Rahul Sharma. He's going to present a case of outpatient cath lab trials. Good morning. I have disclosures there, but for some reason they're not showing. I'm not so sure. There are no financial disclosures. All right, so I was going to show a case of one-handed reverse cart, but I thought that's a CTO joke. I thought I'd show a case that actually was maybe a little bit more on the fun side. So perhaps this may not stand as one of the more challenging cases, but I think kind of an interesting case. This was probably one of my first 5 or 10 interventions when I started my job last year. And you're sort of cath lab doc of the day, you're running around in the morning, this is your first outpatient setup for cath, and then you get hit with a little bit of a surprise. So this is a 66-year-old Caucasian female, history of hypertension, hyperlipidemia, hypothyroidism, remote history of smoking. She'd quit, I think, about 8 or 9 years prior to her presentation. She'd been experiencing substernal chest tightness during her exercise routine at the YMCA, about 15 to 20 minutes into her exercise. This was kind of a new complaint for her, worsening over the last 3 weeks, beginning to feel tightness during some household chores as well. Chest tightness was non-radiating, non-pleuritic, relieved by rest, and no associated shortness of breath. Her primary care physician orders an exercise stress echo. The stress echo, she did about 7.5 minutes. Bruce protocol, achieved around 10 METs, reached stage 3 of Bruce. Rate pressure product 22,400. Exam was terminated due to fatigue. She had normal resting LV function, 60-65%, but at peak stress there was some basal, infralateral basal inferior hypokinesis. Just to kind of quickly show you the stress images, you can see the inferior basal and infralateral mildly hypokinetic. So she presents for cath. Right transradial access, 6 French glide sheath in the radial. My cocktail is just usually 2.5 milligrams of
intraarterial verapamil. Sometimes I mix that with 200 of nitro, sometimes I don't. 5,000 units of IV heparin given systemically, intravenously. I did a left heart cath with 5-French pigtail, and then coronary angiogram using a JR4 and JL35 5-French diagnostic catheters. So here's our left coronary angiogram. You can see there's a prominent collateralization to what I believe is a posterior lateral branch from the right coronary. So now I'm thinking, is this going to be a CTO case, or is this just a really tight stenosis? Obviously expecting something of culprit in the right coronary. To me, the left system looked okay. So then I shoot the right, and this is what I see. See if this next panel plays here. And the right-hand side, of course, is your straight RAO projection, about RAO 30 degrees. And you can see that there is indeed a focal stenosis there in the mid-right coronary, but proximally, I'm concluding this is probably a dissection or multiple dissections. There's also a stenosis distally, right proximal to where you see the continuation of the posterior branch that was collateralized by the circ. So I'm not really, I'm sort of looking at this, and my initial reaction is this. I'm thinking to myself, I've got 4 outpatients today, I've got 2 TEs, I've got to give a fellows talk, and this is my first case, and I'm going to be tied up in this, and I don't even know what is going on here. I've never seen anything like that in the proximal right coronary of any patient that I ever did in fellowship. I basically sort of looked at this carefully, and I thought, this could be, dissection related to her initial plaque rupture. I don't have any feeling that this was any sort of catheter-related dissection. Thinking, do I want to image this? Is it thrombus? There's a lot of different thoughts going through my mind, and maybe we can talk about this shortly. And I thought to myself, well, this is single vessel coronary disease in a symptomatic indicated patient, so we should percutaneously revascularize her. She was stable. This is, again, an outpatient. This is not an ACS presentation. So this is my equipment, and I'll repeat some of this as I go through the images, but basically I used an AR1 6-French guide, stayed right radial, gave 100 units a kilogram per kilogram of heparin, which is typically what I use for my interventions, rarely used by Valirudin. I did give her Effient 60 milligrams as a loading dose. This is, of course, off-label because this is not an ACS case, and Effient was not studied in these kinds of elective scenarios, but I wanted her to have prompt and potent antiplatelet inhibition, and so I gave her Effient with plans to switch her to Plavix in the future. Initially tried an 014 choice PT floppy wire, which didn't go, and then I did a PT2 moderate support, which you'll see what happened with that. And then these are some of the balloons I used. You can see I used large stents, Resolute Onyx 5.0 stents, and then some peripheral balloons for post-dilatation. Again, all of this will sort of become clear as I go on. So on the left-hand side is the panel with the PT floppy, not really going anywhere. I actually let the interventional fellow kind of have a go at it first, and of course this is a challenging vessel to wire. On the right-hand side is a PT2 moderate support, which ultimately went. Initially started by ballooning that mid-right stenosis just to sort of clarify my inflow and outflow and kind of get a better look at the vessel. So I ballooned it there, and this is on the right-hand side. You see what we have. You see there is a distal stenosis in that posterolateral branch. But of course, just a lot of disease throughout the proximate and distal right coronary. So I began stenting really distal to proximal, not so much the very distal lesion, but I kind of wanted to take care of the main RCA first and really kind of get some stents there and open up that portion of the vessel, and then maybe get a better look at what was going on in the posterior lateral branch. So I stented with Resolute 5.0 stents, Resolute Onyx 5.0, stented the distal, then the proximal, overlapped by about a cell or two along the way, stented the proximal right as well. Was sure to cover the ostium all the way out. And this is what it looks like, and now you can see that kind of outflow stenosis a lot better, which I think was important because I wanted to minimize the length of the stent that I put out there and really be sure that I'm covering that lesion. So then I went ahead and ballooned using, this is actually a 3.5 balloon. Post-dilated my stents and stented in that posterolateral branch as well. Big right coronary. As I mentioned a couple moments ago, I actually used 6.0 peripheral balloons for post-dilating these stents because, of course, the coronary balloons don't come that large. For anyone who's wondering, or maybe you all are already aware, the 5.0 Resolute Onyx stent maximum expansion is 5.75, but I really took it up to high pressure with a 6.0 balloon. I went to like 14 atmospheres, 16 atmospheres, and really wanted to make these stents as large as possible. I chose not to image in this case. I really thought about it. I thought, let me just do a quick IVUS down this vessel, make sure that the stents look good, and that, more importantly, that the stents are accurately overlapped. But I felt comfortable with where I placed the stents. I chose not to image in this case. I think if I could go back and do it again, I probably would have tried to image not only on the front end to confirm that these were dissections or what were these indeed, but also perhaps at the conclusion of the case. But I didn't do that. And then basically that's about it. No perforation, no edge dissections, no residual stenosis. Final result looked good. PDA is small. So TR band to the right wrist, switched her to Plavix with a 600 milligram loading dose the next day. She went home the next day. I kept her overnight after this case. Typically we do same-day discharge, but I thought I should watch this one. Guideline-directed medical therapy. At 6-month follow-up, she's doing great. She's returned to her exercise routine. She's completely asymptomatic. So just a couple of the bullet points of this case. Nothing cataclysmic here, but just some basic learning tips that I sort of took away from this. I think it's important to have all your wires and balloons and stent sizes in the room before proceeding. You never know what you're going to get into. A bit of a surprise. This was, I thought, maybe just a focal stenosis to the right, and it ended up showing the right angiogram to look like a complete mess, and not exactly what I expected when I started the case. Hydrophilic wires can be your friend, but they can also be your enemy. If you have a dissected right, or even if it's filled with clot, you can sometimes get underneath something, lift it, and cause further dissection, but I chose to go with one, kept the tip free, got it all the way out there, and it worked out. Choosing your stent sizes carefully, knowing your maximum stent expansion sizes, and being comfortable with using 5.0, 5.5, 6.0 peripheral balloons if necessary for some very large coronary vessels. And then to anticipate the unexpected, just because it's a stable outpatient doesn't mean it's going to be a straightforward case, obviously. So, thank you.
Very good. Excellent result. It looks beautiful.
Thanks.
Obviously, you hit on a couple of points that people might wonder about in terms of using a peripheral balloon. Did you need to upsize to an 0.18 wire for that, or just run it over the 0.14?
I ran it over the 0.14, yeah.
And then, how did you decide what the size of the vessel was without imaging?
Yeah. So I just went with kind of my eyeball gut instinct. To me, it looked like it was a 5.5, 6 millimeter right. I looked at the size of my guide, which was of course 6 French, so 2 millimeters outer diameter, and I just sort of eyeballed it. And then of course I always do a little correction where I just make the stent absolutely as big as I can. As I've progressed over the past year, in my first year on the job, I have used more imaging than I did when I first started. But I also think to myself, this is a large coronary artery, and I think I made these stents pretty big. I'm not really very worried about the risk of in-stent restenosis, but of course we want to make sure that the stents are overlapped, that they're well expanded. I thought they looked well expanded, but of course the only way to know would be to image.
Did you think that it could be a scat?
Yeah, that thought crossed my mind. Actually, as we were preparing for the intervention, we had a lot of time to get our equipment ready and to talk about it and look at all the images carefully. There was no rush in this case. And I thought about SCAD. I thought about, did she have a focal stenosis there in the mid-right, and then some sort of dissection plane originated from that and extended proximally because it could not extend distally. A lot of thoughts crossed my mind, but ultimately, she needed to be fixed.
I was thinking about some disease in a patient that hemodynamically is not unstable. You have a scan on your leads.
Right.
I mean, one could submit that you can
Sure.
just let it go and let the patient be on medical therapy.
Yeah, she's...
And then decide what to do.
Yeah, she's in her early 60s, I believe. She did not have any autoimmune diseases, no previous history of, coronary or cardiac disease. The right coronary looked pretty bad to me. It was a big vessel. I didn't feel comfortable with that strategy, but that might have been something one could have tried.
Did you have some concerns about injecting antigrade during all of this? Because, you have to position your stents and so forth.
Yeah. No, I actually think that focal stenosis in the mid-right was very protective. Very protective. I basically approached this case like I was going to own this artery throughout the case, and extremely expand these stents as much as I could, and just sort of stayed focused and got it done.
Your choice of wire, the choice PT, that's a fairly aggressive, sharp tip
Yeah.
that is being around for 20, 25 years.
Right.
And usually don't give it to the fellows because, it's like a monkey with a razor blade.
Yeah.
So,
Yeah. I figured, the vessel's pretty badly dissected already, and the mid-right's focally stenosis, so I thought I'd give him a whirl.
You can always make it work.
Of course,
So I thought
of course,
that
yeah.
The choice of wire was, was a little bit aggressive.
Yeah.
There's nothing to say, there's nothing with success. So, but
Yeah,
just
no, that's
one
true.
thing
Yeah.
about that choice PT wire, which is not, I think, in one of the armamentarium of the newer modern wires that use for CTOs.
Right.
Can be helpful sometimes, but it's a niche wire.
Yeah, and over the last year, I've had a lot of kind of success with PT2 moderate support wire, Pilot 50 wire. So I've tried those, and they've worked out pretty well. But yeah.
Of course, the other cautionary note is, if you overexpand too far, you will have a dissection, sometimes retrograde to the
Yeah.
aorta.
Sure.
And so some of us who've all seen that, we're a little hesitant.
Yeah.
If you get into 4050,
Yeah.
maybe that's good enough, regardless of what the original size was. And
Yeah.
so I think some of us might have been hesitant to use a 60. The other, I think, lesson point that you spoke to as well is image where possible.
Yeah.
In academic medicine, of course, we're teaching and sharing.
Sure.
The more we know, the better, the more interesting it is for us. And I struggle with this myself. You've got a busy academic practice. You're always rushing off to the next thing. But if we can at least get some imaging, that can help.
Yeah, absolutely. And over the course of the last year, I've imaged much more. And so I think if the present version of myself had done this case again, I certainly would have. And I've been very surprised oftentimes what I see.
Very good.
Running 5 minutes.
Yeah.
Thank you.
Okay, next case is Arslan Shaukat, use of CTO PCI technique for salvage.
Hi, good morning, everyone. Thank you for giving me the opportunity to present my case here. Nothing to disclose. And I recently completed my interventional cardiology fellowship at the Minneapolis Heart Institute and Hennepin County Medical Center in Minneapolis. And this was one of the cases during my fellowship. So the title of my case is Use of CTO PCI Technique for Salvage. So the case is of an 83-year-old female, and she had all the risk factors for coronary artery disease and also had CKD stage 3, presented to our hospital with worsening dyspnea, no real chest pain as such, mild troponin elevation, and her echo showed an inferior wall motion abnormality and an ejection fraction of 40 to 45%. So her initial angiogram was done right radial, thought to be potentially something straightforward. So this is the right coronary artery. I'll try to plead again here. And if you can appreciate there's a little bit of overlap, but there's a very tight, tortuous, potentially calcified lesion in the mid-RCA there, which obviously looks like the culprit. This is an RAO view there, lays it out a little bit better. Again, you can see the tortuosity there. Definitely very tight lesion. Difficult to appreciate how calcified it is there, but the initial, and so this is the injection of the left coronary system on the initial angiogram, and you can see that there's actually collaterals that are filling the right PDA and the PLV branches there because of that subtotal occlusion. So the initial PCI was attempted at that time from the right radial approach. Different wires were tried, and a run through a Fielder FC, a whisper wire, and then a Pilot 150 supported with a microcatheter was also tried. But what essentially happened was that the wires tended to go subintimal, and because of that, essentially ended up with a dissection and acute vessel closure at this point, as you can see quite clearly here. So at this point, luckily the patient was chest pain free. She'd never actually had chest pain even to begin with. We thought that her dyspnea was her anginal equivalent. So at this point, there was discussion among a couple of different operators about what we should do here. She did have a CKD stage 3 as well, and we had used some contrast already. And so we decided to abort the procedure here at this point, given that she was also fairly stable symptomatically and hemodynamically. And we thought that we should bring her back and try and use a CTO PCI technique, given that we had seen collaterals going from the left and filling retrogradely and filling the branches of the right coronary artery. So we brought her back. This is her dual injection, as you can see here. So the flow on the right side is a little bit better now. It's recanalized a little bit, but there is still collateral filling, and we thought that there were perhaps a couple of septals that were still supplying good collaterals. So we initially tried an AL1 guide catheter for the right coronary, but it actually didn't fit very well, so we ended up having to use a GR4 for the right and an EBU375 guide catheter for the left. So we initially thought, okay, maybe we can give it another try, antegrade. Sometimes you can form a little microchannel or something like that. And so we tried a Samurai RC and then a Fielder FC guide wire antegrade with a Mamba microcatheter, but ended up with essentially the same problem. It kept going subintimal. So we said, okay, I think we've had enough of this, and really going by the hybrid algorithm, although it is not technically a CTO case, we should switch strategy and go retrograde. So we advanced a Samurai RC guide wire down into the LAD. We usually try to keep a guide wire in the LAD as well, even while we're crossing into the septals, just in case something happens to the donor vessel there. So as you can see, so there's guide wire there, and then we had another Samurai RC with a Mamba microcatheter. We went into the first septal and did a microinjection there, and didn't really see a great connection from that one. So we switched to another septal. And here we thought that there was a good connection. We did septal surfing. We did use a Scion wire here, and with surfing, and then we were able to cross this second septal collateral and all the way and went into the distal RCA. The Mamba microcatheter would not cross the septal, so we switched to a Caravel because of its lower profile, and it tends to do better with small and tortuous collaterals. So the Caravel was able to make its way through to the distal RCA. So now that our retrograde wire was there, we thought, okay, let's try a wire escalation technique initially. But again, even though the lesion and the subtotal occlusion was fairly short, again, our wire continued to go subintimal, and we really were not successful. So at this point, we have our antegrade wire that to the point of occlusion, and you can see our retrograde wire is still clearly subintimal and not really tracking in with the true lumen that the antegrade wire is in, or that we thought it was in. So at this point, really what we did was we decided to perform a guideliner-assisted reverse cart. So as my previous presenter mentioned, this is a two-handed reverse cart. So what we basically have is it's an 8 French guideliner, and we switched for a pilot 200 guide wire retrograde. Initially, we used a 3.0 and then a 3.5 balloon, and really what we were using was called the draft technique, and I'll show this here, which stands for deflate, retract, and advance into the fenestration technique, in which one operator is able to inflate and then deflate and retract the balloon over the antegrade wire, while the other operator can simultaneously, while you're retracting your balloon over the antegrade wire, push the retrograde wire hopefully into this space and hope that it tracks from subintimal space into the true lumen. So as you can see here, that's what we were attempting to do. So when we were not really being successful with the 3.035 balloon, we did IVUS at this point to see exactly what was going on here. And what it showed us was, one, it showed us where the wires were. It showed us that the antegrade wire was in the true lumen and the retrograde wire was subintimal. But the size of the RCA was larger than we thought, and it was more of a 4.0 vessel. And so we used a 4.0 balloon and decided to repeat the maneuver here. And as you can see here, there's a sort of a long fluorostore there, but right there, as you can see, the wire eventually did track the balloon into the guide liner there. And after that, we were able to advance our microcatheter retrograde into the guide liner and into the guide. We swapped that out for a R350 externalization wire, and over that, we were able to deploy 2 stents there. one long one, and we had to do one shorter one there, and it really got an excellent result at the end. So the take-home messages from this case, one is that PCI of complex lesions can always be complicated by acute vessel closure due to dissection. It's always risk and can be catastrophic. Luckily, in our case, it was fairly well tolerated by the patient. If good collaterals are available, you can try and use retrograde CTO PCI techniques for bailout in these cases. Thank you.
Very quickly, in the interest of time, any comments?
Very nice case, Arslan. I completely agree with this draft technique. I've been in a number of cases that you're like 20, 30 minutes, you're trying ballooning, trying to, do the draft, the cart, and essentially as you do the draft, I think it's very nice cartoons. I think it's Carlino and Colombo a number of years ago had a technique you just balloon and essentially will suck down the wire into the catheter retrograde. It's a beautiful, very nice case.
Yeah, no, I agree. I think it does. The few times that I've used it or scrubbed into those cases, yeah, I think it works. I think it works well because I think it helps track the wire, sort of, like you said, sucks it in that way, and it worked. And I think the other thing that commonly happens is that you tend to undersize your balloon when you're doing a reverse card, and so I think an appropriately sized balloon also helps with it. If it's undersized, I think you can keep trying over and over and it won't work.
Very good. Yeah, please. Next case will be Dr. Azzam again. Is that correct? Successful removal of stuck rotablator bird.
Thanks again. Nothing to disclose here. All right, so I'm presenting a case where a rotablator bird got stuck in a coronary artery. Basically, this is a 58-year-old gentleman known to have coronary artery disease. He had multiple interventions in the past. Then in 2009, he underwent bypass surgery with Lima to LAD, SVG to OM, and SVG to left PLV. He was Cath back in 2013. They found that graft was closed. Several years ago, also, he had a stent in the proximal and mid circumflex arteries and diagonal. So he recently underwent attempt at PCI of distal left circ and multiple left PLV branches by another operator, and that procedure was aborted as no balloon would cross. He continued to have dyspnea on exertion, chest tightness with minimal exertion, fatigue despite multiple anti-ischemics. So this is a left angiogram showing the left circ with densely calcified artery, right proximal to all these PLVs and PDA. There is no competitive flow seen here. That graft was known to have closed before 2013. So I proceeded with what I thought would be a regular intervention. So I used a 6 French JL4 guide. I wired that artery using a Pilot 200 supported with a Corsair, then exchanged it out, the wire for rotafloppy. I used 1.25 millimeter burr. 3 passes went very uneventful. I was able to rotablade the whole length all the way down. The 4th pass, the burr got stuck. So we checked our equipment, the tank, we checked everything. Everything was okay, but the burr wouldn't work anymore. Pull and push didn't work. We called the cardiac surgeon at that time. We continued to work here. The patient at that point was hemodynamically stable. I wanted ACT to continue to be between 370 and 400, 420. So I obtained a contralateral femoral access, used a 6 French EBU 375 guide. I wired the circ with a Pilot 200, then advanced multiple balloons trying to dislodge the burr. I started with 1520 and 30. Here 2 wires, but still the burr is stuck. So the cardiac surgeon was in the room and said, continue to do your best. So I did. What I did is I disassembled the advancer. We cut the rota sheath. I used this as my wire now, try to advance a 6 French guide liner over it all the way into the left circumflex and try to get it dislodged. It didn't work. So, so far a contralateral access failed. Using this wire as my railroad also failed. I decided to upgrade the system for an 8 French. The problem is this wire will not be supportive. I advanced a J wire into the guiding catheter in the left groin where I was doing this intervention, pulled the guiding catheter out, JL, and now I ended up with this system, this wire, a sheath, and a J wire. These would not permit me to advance an 8 French sheath with the dilator. The dilator would not accept it. And I didn't try to advance an 8 French sheath over just this. I didn't want to cause any vascular issue in addition to what's happening up in the heart. So what I did is that I brought an 8 French GR4 guide and cut it here. I took the dilator of 8 French out. I used an 11 centimeter 8 French sheath and then advanced inside it an 8 French multipurpose guide and this part of the cut, an 8 French cut JR with a 6 French guide, and I telescoped all of them. We're also using a 6 French guide liner. So what I had now, a guide liner inside a 6 French multipurpose guide, inside the cut 8 French JR4 guide, all inside an 8 French sheath. With a J wire and the rota sheath. I advanced them all the way into the femoral artery, then pulled them out. At that time, I had the J wire and rota floppy sheath. After that, I used an 8 French multipurpose guide and advanced a 6 French guide liner. Inside this 8 French sheath. Then I used a body wire. I advanced it inside the circumflex, inflated a balloon just to anchor, and advanced the guide liner. I didn't have, again, 8 French guide liner at that time. With an inflated system, an anchored system, I advanced the guide liner and very cautiously advanced the multi-purpose guide all the way close to the where the burr was stuck. Then deflated the balloon, pulled the body wire and the balloon out, and maintained firm pressure on the rota system and the guide liner, and pushed the multipurpose guide inside and got everything out. So this is what I found. The rota burr chewed a very old stent, longer than 3 years. It was deployed longer than 3 years ago. Part of the artery came out, and there's some stent here, also there. This is the tip of the wire with a lot of old stent here, and this is the guide liner. The patient continued to be hemodynamically stable, which was great.
Was there an angio?
I was
Is there
sweating.
an angio part of this?
Exactly. So this is, yeah, and interestingly, actually, this is an angio immediately after I pulled everything out.
It was therapeutic.
Yeah, right. Yeah, atherectomy.
Yeah,
Exactly.
Unorthodox,
Yeah.
endorectomy.
Yep. So now I just, after that, I advanced a wire, IVISed that part, and then ballooned distally proximal and deployed a 3028 stent in the proximal to mid circumflex, post-dilated distal with a 2.0, and got a good result now. Oops, sorry. Yeah, got a good result. Yeah.
So you're either very lucky or very good or both. That's pretty amazing.
Well,
we
I was
did
his
it.
fellow.
Invariably, it's the 1-2 fibers that want to get
they wanna
stuck.
get
So
Yes.
rare situations I'll use it, really small vessel or whatever, but I try to get away from 1-2-5. It's always the circ that gives you trouble.
Yep.
It's always when you use a 6 French jail for
Mm-hmm. Yes.
it's perfect.
The reason is because 1-5 back end is flat, as opposed to the 1-5 which is baseball.
True.
So most of the time.
That was literally the last time I used a 125, and this was years ago.
Yeah.
Yep.
I use one for only the 1.5
Yep.
for most, like 99% of my cases, and then I will upsize to 1.75.
Yes.
Okay, should you have it? One cat question back to 1.75.
How do you know that it was stuck on the stand?
I didn't.
But how do you know? Would have you kept like wing,
If
stone?
yes, but I wouldn't have used any balloon actually trying to dislodge anything. I had no idea that it showed a very old stent. I mean, until now, I don't know why this happened. Three successful passes without any problem, and then the fourth, it got stuck and showed a very old stent that's fully endothelialized.
So you had a wire passing across it. You try to advance a small balloon and see if you can put a 1-5 balloon or 1.5 balloon at the side that is with
Over which wire? The body wire or the?
second wire that you put in.
Yeah, I did.
Inflated
Yeah,
the
yeah,
balloons on
yeah.
the side.
How did you get the 8 French sheath in the groin? Because that can be tough too.
Yeah, well, so I telescoped way too many things. I had to cut a guide.
You use that as your dilator.
Exactly. Yep.
They didn't teach you that in Miami.
No. Well.
Very good, very
Yep.
creative and very
Thanks.
successful.
Yeah, thank you.
Move on. Next case is Eric Ransall, using OCT to make a challenging case simple. Just use the touchpad or this thing.
Yeah, that's much easier.
Yeah.
Great. Hi, my name is Eric Bansel. I'm a second-year interventional fellow at Case Western University Hospital in Cleveland, Ohio. I just wanted to thank everyone for having me and allowing me to present this case today. So the topic of, or the title of my presentation is Using OCT to Make a Complex Intervention Simple. So this is a case of a 53-year-old male with history of hypertension, hyperlipidemia, who was actually referred to University Hospital for rotational atherectomy of a diffusely calcified LED lesion seen on angiography at one of our satellite university hospitals. The patient had reported some substernal chest pain with moderate exertion, and this actually, interesting, all started when the patient had an elevated calcium score about 6 months prior. He subsequently had an abnormal stress test and was referred for diagnostic angiography. On physical exam, vitals are pretty unremarkable. Physical exams are unremarkable with the normal or creatinine of 1.2. This was his calcium score. Actually started his whole work, and as you can see, the concerning, the driving force of this elevated calcium score was an LED calcium score of 917. And so he was referred for diagnostic angiography. This was done at the outside hospital, showing the right. It's just short left main, and they were selectively engaged in the circ. But we can see eventually that there is some better pictures of the LED and the calcification that is in the LED. I think this picture probably shows it the best, showing a diffusely narrowed mid-LED with severe calcification angiography, where you can see the outline of the vessel due to the calcification on both sides of the vessel. Again, more angiography that was done.
just kind of highlighting the significance of that LAD stenosis. So he was referred to our institution for rotational atherectomy. So just kind of going over the goals of the atherectomy would be the equipment delivery, calcium debulking, and calcium fracture loss stent expansion. And so we often use OCT prior to any atherectomy case to kind of identify where the significant calcifications are and to kind of figure out what is the best approach to these patients. And we often use this kind of treatment approach where if there's concentric calcification, meaning greater than 270-degree arc, we go to atherectomy, but oftentimes we're able to avoid atherectomy if we find that the eccentric calcification is not concentric, and it often changes our management style. So in this case, as we often do, we use OCT almost exclusively in these patients, and this is our OCT run of the vessel. There is a tightly narrowed segment in the mid-LAD just prior to that diagonal. But as I will show in the subsequent slide here, so looking at OCT, we ask ourselves 3 questions: will the calcification prevent stent delivery? In this situation, there is there's still a prominent lumen there. Will the calcification prevent stent expansion? And this is kind of breaks down the calcification in this vessel. And as you can see here, I kind of highlighted the calcification in the lower panels of this picture. In panel 3 here, which is the worst area of calcification just prior to that diagonal, the calcification is more on the 180 arc, but definitely not 270. So in this situation, and then also based on the OCT, we were able to identify good landing zones for our stent. So going back to identifying this calcification pattern, we felt that we actually could proceed with stenting this lesion, and our stents would probably be D-shaped stents, but we would achieve good lumen gain. So OCT in this case, the calcification was thick but eccentric, so it would allow adequate stent expansion against that non-calcified wall. There was good landing zones present, and so we actually proceeded to direct stent this vessel with a zeralized eluting stent at 2538, which is post-dilated up to 3.0 at 20 atmospheres. This was a result after our initial stent. We decided to treat the diagonal, which was treated with a 3.0 and then eventually kissing balloons into the LAD. This is our subsequent picture. We did repeat another OCT run, and kind of based on operator preference at this point, there was an area of stenosis a little bit proximal to where our stent landed, as we'll get to that here in this OCT run, and kind of a little bit subjectively, I'll admit that we decided to stent that lesion as well. So that was stented with another stent, a 3.012, post-dilated up to 3.5. This is our final OCT run here, showing our final results with with the 2 stents in place now. I will break this down here in the next slide. I just wanted to go over it and let it play in its entirety. And so then this is our final angiogram. So basically in our final OCT, we had no edge dissections. There was no significant malapposition. And we had adequate stent expansion, which is largely assessed by the lumen profile, and all of this made for successful PCI. So we avoided a trapped rotablator burr, and we avoided all atherectomy, and we were able to successfully treat this patient, and OCT greatly facilitated us making this challenging case simple.
Very good. Any comments?
No, it's great case.
Good use of technology to simplify it. It's too bad the CT can't tell you that it's circumferential or not. It would be also very nice, but the blooming artifacts tend to make it a little inferior in that regard. Very good. Our next presenter is Dr. Amer Alaiti. Think outside of the box.
Hi, everyone. Thank you all for being here today. Okay, exit. While it's loading, just want to ask, like, how many interventional fellows in the room? If you can raise your hand. Oh, that's it. Well, I cannot ask any questions then. Okay, so my case title again is Think Outside the Box. And so 48-year-old female with no known cardiac history She presented to outside hospital ED September 15th with acute worsening chest pain and also like 3-month history of worsening chest pain on exertion. Past medical history, nothing cardiac. Surgical history, just knee replacement, hysterectomy for abnormal uterine bleeding. Family history of hypertension, CAD in the mom side. She denied smoking, but she admitted to smoke marijuana every day. And meds, just anti-anxiety, no allergies. So her, like, just a quick summary, like how her symptoms evolved. She really described like discomfort in chest for about 3 months duration, substernal, some mixed kind of typical and atypical symptoms. Then in August, she presented to outside hospital ED with a chest pain, 10 out of 10, sweating, nausea. Troponins were negative, EKG, no acute changes. She was labeled with anxiety, discharged on Xanax. She went to Jamaica for a vacation, September, and there she had also some atypical symptoms of cough, URI symptoms, also acute chest pain. So she eventually presented like on the 15th September with chest pain after going to urinate. She felt acute chest pain with diaphoresis, dyspnea on exertion, nausea, vomiting, more typical symptoms. Obviously, like any patient going through the ED, she got CTAPE study that was negative. This time, if you just look like, is it like, okay, so basically in August, she had negative troponin. Upon presentation, she had troponin of 0.08, and this time really peaked into like to 1, which is really concerning. This is the EKG in August. This is the EKG this time, which is really more concerning with, kind of well on kind of sign. On the EKG physical exam, nothing remarkable. She had chest wall tenderness for whatever that was. Okay, so the angiogram. Like just quick question here, like anybody concerned about anything in this images? Kind of ectatic looking, proximal LAD, even the left main, and weird takeoff of the LAD. Obviously the cranial view, you see the LAD here, kind of ectatic. And in this view is like really diving down and then up in this RAO caudal. So just like any, if you're really concerned about the clinical scenario, just like any other case, you take more views. And in this view, which is RAO caudal, but more kind of maybe steep RAO, there is this ostial lesion, or whatever it is, something is suspicious in the ostial LAD. With this history, this is the RCA, and the LV gram here, LAD distribution, wall motion abnormality. So I think it's not unreasonable to have like SCAD in differential diagnosis. And the operator at that time felt, she is hemodynamically stable, you have timid flow in the LAD, ostial LAD. If it is a SCAD, if you try to intervene, you might just make things worse all of a sudden. So the plan was to send her to our center, cardiac ICU, and really kind of discuss the options. If you're concerned about SCAD, I'm not sure if anyone concerned about anything else at this point. Kind of, conservative management, maybe watch her, see how she does, repeat Cath or imaging, the CT, You don't want to rush her to the Cath lab, but probably you consider like cardiac, surgery just to see the patient in case she become unstable. She was hairplanized, monitored, and as we discussed. So she was having more chest pain, just because of, to cover, a kind of heart team approach, we called CT surgery, and she was very, very upset. She said no, she kind of kicked him out of the room. She doesn't want to consider any options of open heart surgery. But she had, it was a weekend. We kind of were trying to put off things like, let's just wait, see how you do, because, the concern of SCAD. But she had worsening chest pain. On the Sunday, we just kind of looked at the CTPE that she had. There was like unusual, obviously this is not optimized to evaluate coronaries, the contrast in the PA, but you can see like there's calcification in the ostial LAD. There's nowhere else, any calcium anywhere else. Okay, so we repeated Cath on a Sunday, looking the same. I mean, obviously, you would like to get more data, and I think everybody would agree you would try to maybe image it. Maybe consider FFR if you want to intervene. Anyway, for the sake of time, very difficult to wire. Angulation, severe lesion, you cannot really open up in any good view. We used superclass, and with difficulty we were able to wire it. We did FFR just to kind of complete the evaluation, and very ischemic. And we did OCT. And the OCT, you can see it's like really big vessel. Don't worry about this, this is just artifact from a huge vessel. Kind of, you see how the OCT is kind of biased into the other wall here. So there is no evidence of atherosclerosis. Here's the transition from the LAD to the left main. I will repeat that because that's the key here. So again, the things that we were looking for, no atherosclerosis. So we're not dealing here like with a athero lesion. There is this transition from the LAD into the left main. Very unusual. Again, no athero, it just looked like a kink or a twisted artery. This is not a great image. This is 3D reconstruction of OCT, but because of the artifact and the, all of these things, but you can appreciate how the LAD here and the left main, and this is like kind of twisted and kinked. Then obviously the next question is how do you deal with this? We obviously already kicked out the CT surgeon from the room, from her room, she did. So there's no option of surgery. Obviously PCI, we went with the larger stent. The actual left main was like 10 millimeter probably, LAD approximately, also probably 7, 8, a huge vessel. You can see how the wire is biased from like this wall in the left main to that wall of the other wall of the LAD because of the whole anatomy is strange. Went with the larger stent, 5 by 12, and we just deployed it. And we did another OCT. It's just the final results here. Okay, kind of straighten the segment. Obviously, I think everybody wants to know how the OCT looked like after this, and this might spark like a lot of questions. We're happy to discuss it really quickly, but for the sake of time, I'll just scroll here, show you. You can see the stent. I admit the stent is floating in the LAD, but again, it's like about 8 millimeter or even more vessel here. And this is the kind of the segment that we kind of straightened with the stent, and it's floating also in the left main. We did not post-dilate. I think we can open that to discussion quickly, but we did not post-dilate. I think for this, the whole idea here is to support that segment. We're not dealing with atherosclerosis, we're not dealing with a lumen area. This is like the left main was 32 millimeters square, similar to the LAD, so we're not worried about stent thrombosis. And you don't want to deform the stent, because then you lose the whole idea of supporting that segment, the kinked or twisted artery. Okay, I think I already showed you this, but before and after, and thank you all for the attention.
Very good. I had one case just like this on a young patient, 30-year-old, and she had a scleroderma crest syndrome. And I think that, totally clean arteries, no atherosclerosis anywhere else, but just focal.
Just like focal,
LAD,
okay.
And we ended up sending it just like you did. I think it's an open question whether you should post-dilate this one with a peripheral balloon. I think that's a reasonable question here, given the size of these vessels. But
You'll probably never get apposition from what he's describing, so you might mangle the stent. One thought is to use a renal stent, Herculinic or something that you can take bigger.
I think that anyway, I think it's very risky. I think that if you dissect proximal or distal, you're in big trouble, and that the patient may go into a path of no return, because it's almost immediate shock if you even either dissect distally or proximally. Sometimes the implant can be like tissue paper, especially in a young female. She's 40.
She's 42, 48.
42.
Yeah, in the
so
40s.
I would think about non-atherosclerotic.
Yeah.
Even though she had calcium, she showed calcium.
So that
or
calcium, I think she had like long-standing issue in that segment. Inflammation from a kink, that progressed over time and then acutely worsened. So there was like some focal, abnormality there for a long time. That's why she had calcium there, but it was not atherosclerosis.
A mid-cab or something that is less invasive and secures I mean, that's definitely significant. So the only problem is that there's so much inflammation that this may open up in the future. If you put a graft, the graft may not work, but at least to get you out of the problem. But it's interesting. It's an interesting approach.
Fortunately, we know that stent expansion is adequate, and so you don't need as much apposition. It's
Exactly.
stent expansion that's the risk
Exactly.
for stent thrombosis. So I think you did the right thing leaving it alone. Let's move on to the next.
One comment, as big as this artery is, it's like an SFA in the heart. And so basically, there is so much twist that, people have used self-expanding stents. And, that could be one option to actually put in a self-expanding stent. You get, a much bigger lumen. You can post-dilate it. You probably have less risk of dissection, perforation at the edges. Exactly, a carotid stent, I've not used it in the LED, I've used it a couple times in the RCAs, but I mean, that might be another option, just because the way it is, it's,
Yeah, that's a
now it's-
great point, and that's why you guys are all dual trained in vertical. It's wonderful.
Hi, very nice presentation. So the presentation of this patient was ACS, was it?
Yes, the last one she presented with was ACS.
The reason that you put in a stent was ACS?
I mean, yeah, because she had like this time NSTEMI, it's a 0.1, LV wall motion abnormality, like EKG changes, everything was consistent with, and FFR was 0.5. Yeah, we did FFR, yeah, it was 0.5. We were trying to do everything that avoid doing anything, intervention, but we couldn't.
All right, we're going to move on to Dr. Thank you very much.
Thank you.
Next case is Please Mind the Spasm by Dr. Sanidas.
Good afternoon, everyone. My name is Dr. Sanidas. I used to be a fellow here in the United States, and I'm now practicing back in my home country, Greece.
Those are your files. You need your people.
Scroll them down.
Scroll down, really.
If you want to start. So these are my disclosures. This case is about a 40-year-old male Caucasian patient, heavy smoker with no prior medical history and no drug abuse, according to his testimony, who presented at the ER with a non-ST elevation MI. And after the administration of the original medications, the plan was to perform an angiogram via the right radial approach. So you can see this is the 6 French diagnostic Judkins right catheter, and this was the right coronary artery, a relatively small artery with no disease. This is the left system, dominant circ and a little bit of overlapping and tortuosity. And again, these are the images. And from the still frames, you can see that there is something in the LAD and the diagonal branch. So this is, you can see the LAD, there is something just before the takeoff of the septal perforator branch, and there is also something in the diagonal. So our impression was that this was in one vessel, in one major branch, significant disease, according to Medina classification 011 lesion. So the strategy was to treat both vessels with DES and a dedicated bifurcation technique, since the ostium of the diagonal was very close to the LAD lesion. The first BMW wire went to the diagonal branch, and then the second BMW wire went to the LAD. And you see here nothing after wiring both vessels, and then we removed the wires. And again, in summary, the first wire went to the diagonal branch, the second wire went to the LAD, and no visible coronary artery disease after wiring both vessels. So this is the final picture without the wires, no disease, no PCI. And the verdict was that the patient had the non-ST elevation MI due to severe coronary artery spasm. And we decided to treat the patient medically with dual antiplatelet therapy, beta blockers, nitrates, and statins, and maybe at the second time to perform an acetylcholine test. However, 2 months later, the patient came back with typical chest pain, but without any ECG changes, while he was still under medication, but continued smoking. And the next day, we decided to perform a treadmill test, which unfortunately was positive for ischemia. And then, a couple of days after, we did a thallium scan nuclear test, which was also positive for ischemia in the apex. And running out of options, we decided to perform a new angiogram via the left radial approach at this time. You can see this is the left system with the dominant circ. There was nothing there, nothing in the LAD and the diagonal branch. And you see that from the still frames that there was no disease 2 months after the initial event, despite the 2 positive non-invasive tests. And this was the story. At the baseline, we had the non-ST elevation MI, and then we had the initial procedure without the PCI, and 2 months later, still, there was nothing there. So the patient had coronary artery spasm, even though he was not a female with Asian origin. He was just a 40 years old Caucasian male, and he presented with typical acute coronary syndrome. And presumably due to heavy smoking and thus with inflammation or endothelial dysfunction or even an autonomous nervous system stimulation. And our diagnosis was done with coronary angiography. We never performed or confirmed the diagnosis with the provocative tests. And the treatment was medication, only medication. And in these cases, most of the patients, they are doing fine in long-term outcome. However, this patient had a multivessel coronary spasm that sometimes has been identified as a predictor of adverse prognosis. And the patient had also a high-risk coronary spasm score that classified him as a very high-risk patient. In conclusion, coronary artery spasm is a possible cause of ischemia and acute coronary syndromes. Many proposed mechanisms and risk factors, including smoking, endothelial dysfunction, and inflammation, have been proposed. Medical therapy is the gold standard treatment, and of course, in the vast majority of the cases, there is no need for PCI. FYI, the patient is doing fine. He quit smoking, and he is still under medications. Thank you so much for your attention.
Did you use any medications in the lab the second?
No,
the second time?
we didn't have, no.
I think it's an
No
excellent
nitro and
case.
nothing, yes.
Quickly missed. Your case was a little bit more dramatic with an NSTEMI. I had an elective patient, chest pain. Did an initial picture. The LAD was completely shut down. ST elevations. I thought the patient was going into shock. She was. The LAD was gone. And I wired, but in my hospital, that counts as a failed intervention. I gave nitro after the wiring and everything resolved. So the case was reviewed because it's the C-port restricted, but excellent case.
What beta blocker did you use?
Low pressure.
Would anyone use calcium channel blockers instead?
Yeah,
Yes.
we also, at the second time, we use Syscore, nisoldipine, which is something that we use in Europe a lot. I don't know if you have it here in the United States, yes.
What do you have in your radial cocktail? Do you have any verapamil or nitro?
We use usually nitroglycerin and heparin, and verapamil is not our everyday practice, but sometimes if you have spasm in the radial artery, then you have to inject. But not at this time, not at this patient.
Had a similar case to this about 3 months ago. 2 presentations just like your patient. On the 3rd presentation, the patient had pan spasm in all 3 of the coronaries. Actually had put an impella in and subsequently actually stabilized and actually went to urgent cardiac transplantation. Got very, very sick. So this can be a very egregious presentation in rare circumstances where there's tremendous myocardial damage and scar from permanent spasm despite using multiple medicines to alleviate the spasm. In some cases may not work, and having to put support in quickly and then escalate the patient's support as needed, whether it be ECMO, potentially transplant, if it's a reversible situation.
Well, my guess is that there is something like drug abuse or something that they usually don't mention, they don't bring up, or it's something like something more rare condition like Cooney syndrome that we saw at the previous session.
Focal spasm, would you guys ever stent for refractory medical therapy? Would you ever stent focal spasm that's recurrent?
No, I think it would be both actually.
Spasm somewhere else.
Yeah.
But I think there are certain circumstances where people think it's a stenosis and they've stented it, and then after the fact they realize they just stented spasm.
So it's important to give a nitroglycerin.
Exactly.
Don't do it talking fellowship.
Always give nitro if you can.
Even when they're hypo, that's the key though, even when they're in shock, so it's.
Yeah, the problem is that if they evolve into shock, then the reflex is to give more pressure, so that worsens the vasospasm, and then the patients go into, into
Even on a hypotensive patient, 50 of nitro can still be tolerated pretty easily. All right, let's move on
And
to-
also please keep in mind that these are non-normal vessels. They are non-atherosclerotic vessels, but still there is endothelial dysfunction, so they don't react normal. Thank you.
Okay, thank you. Next case is Dr. Gadella, a successful PCI of severely calcified arteries.
Good morning, everybody. My name is Mahidar Gadella. I'm a second-year general cardiology fellow at University of South Dakota.
All right, start instead. All right, you might have to come back to it, unless you have it on your USB drive.
Yeah, I have it in my USB drive, yeah.
Why don't we move on to Dr. Stegman first, while we get the next one ready. Is axillary approach.
All right, so sorry for not having a cool name to my talk. Let's start here.
It's just a time delay.
Just takes a second? Okay. So my name is Brian Stegman. I'm one of the interventional cardiologists at the Central Care Heart and Vascular Institute in St. Cloud, Minnesota. So thank you for letting me come and present my case. So there's a lot of clinical history here, and I apologize for all this, but you kind of need to know it to understand my state of mind going into this. So 67-year-old guy, about a year before I met him, was a pretty healthy guy, no major medical problems. Had a contained rupture of a AAA. Underwent emergent open repair with aorta bifemoral grafting. This was complicated by colonic perforation requiring resection and colostomy, splenic capsular tear requiring splenectomy. They were unable to close his abdominal incision, so he was left to heal by a secondary intention, and he also had a non-ST. During this time, had a Cath from his right radial at that time, demonstrating a CTO of his right and a severe mid-LAD stenosis. So he presented to our institution, to one of my colleagues, complaining of increasing dyspnea and exertion. He talked to surgery. They said, we're just going to let this heal. So the plan was to proceed to LAD PCI. He came in for angiography, and exam at that time demonstrated occlusion of his bilateral radial arteries. He had a prior CT scan that they looked at, showing that the graft to the left CFA was anastomosed and the distal CFA, and the proximal SFA was occluded. On the right, he did have a patent proximal SFA and profundus, so the plan was ultrasound access of the distal right CFA. So this is his coronary angiogram. So he has some kind of borderline stenosis in the first OM, has that severe ostial stenosis and this severe LAD stenosis. I'm not sure how well this projects, but it's a little grainy, but is pretty severely calcified, especially in the mid-LAD and the ostial LAD. And this is his right, chronically occluded, but with good collaterals. So given his new ostial LAD disease that was extending into the main, the decision was to send the patient for bypass surgery, or at least evaluation for bypass surgery.
Unfortunately, he had the sheath removed under manual compression, had severe right lower extremity pain. Exam demonstrated an occlusion of his aorta bipham graft. He underwent emergent surgical embolectomy and PTH of his popliteal artery for a clot. Actually did exceedingly well after that. Was medically managed for his coronary disease for some time. Actually underwent attempted closure of his abdomen and reanastomosis of his colon, which was complicated by a perforated anastomosis and extensive bowel resection, and the guy was on TPN. So he came to see me after he had been on multiple antianginals and was kind of not doing too well. Couldn't walk to his mailbox without getting really short of breath, had an EF of 45% with an inferior wall motion abnormality. So when I saw him, I was wondering about, is he even going to absorb P2Y12? What's his access? Do I need to do atherectomy? There was a lot of calcification in the LAD. And do I need support? So I put him on prasugrel for a week and did a P2Y12 inhibitor panel, and it looked like it was good to go. I ultrasounded his radials, and he had bilateral radial occlusion, but on the right it was occluded all the way to the brachial. On the left it was kind of a fairly short segment occlusion. So decided I would go left radial, just halfway up the arm. I did feel like we needed atherectomy, and because of that, I did feel like, and because of all this other history and my general nervousness going into this, I felt like I needed support. So did a CT scan of his subclavians, and this is a recon of his left axillary, and you can see the measurements all measure pretty big, range from 6 millimeters in the mid-subclavian out to 8.5 in his axillary, which we often see. So I decided at that time, after talking to him for a while and kind of trying to dissuade him a little bit, that, you know, we'll go ahead and try this from the left radial. Obtained ultrasound-guided left radial access because I was ways up the arm. And through that, put a pigtail, did an angiogram of the left axillary. So this is kind of, we do a lot of axillary access in our center, and this is kind of our usual protocol. We mark it under fluoroscopic guidance, and then under ultrasound guidance, get access. This is accessing trying to avoid the branches, accessing the axillary artery, and perform pre-closure, place the impella sheath, and this is the impella placement. So I don't know how many, you guys do a lot of axillary impellas, but the sheath always kinks, and it kinks a lot, and you kind of have to do this push-pull technique to get the impella to cross through the sheath, but it generally goes. This is our angiogram to start. So you can see there was a little bit of ostial left main disease that Ivestin is huge and is actually just kind of how it takes off, and there's really no disease there. And there's pretty severe stenosis in the mid-LAD, which looks like it's progressed from previously and has that severe ostial stenosis. So I did decide to fix that circ, put one stent there, performed orbital atherectomy, about 4 or 5 passes at low speed in the mid-LAD, and then 2 passes at low and 2 passes at high in the ostial LAD. This was unfortunately the only picture that they took of it, so you'll have to believe me. But that all went pretty well. I was actually very happy I had the impella, though, because on about my 3rd pass of CSI, he kind of lost all pulsatility in his, on the impella waveform and on our pressure waveform. I honestly don't exactly know why. I looked through everything. There was no dissection. We had good flow, but came back after about 3 minutes. Ballooned his LAD, stented his LAD, had a little bit of distal edge dissection there, and put another stent there. Stented the LAD into main there, and then post-dilated the ostial LAD and the mid-LAD, and then post-dilated with a 6.0 balloon in the left main, and opened the side branch of the circumflex. And this is our final angiogram. I left that ostial diagonal stenosis. Felt like that was reasonably medically managed. So this is our impella removal, coming out again through the kinks. So we generally put an occlusion balloon distally when we're closing, just to make sure that we don't have a whole lot of, we obtain good hemostasis. So this is the picture from that, and this is our final post.
You said you pre-closed?
Yeah, yeah,
Just one?
two.
Two.
Yeah, yeah. Kind of make that decision based on how big this was a big artery, so. And this is what our sheath removal site looked like. And follow-up, I saw him at about a month. His shortness of breath had significantly improved. He's doing a lot better. He remains stable on the TPN, and I'm going to medically manage the CTO unless otherwise needed.
So, good case. The only thing I do different is I use floor roadmap, so DSA for axillary puncture. So,
Okay.
you know, even if they're breathing, it doesn't move much, and you can just visualize where you want to go. And then I do a DSA picture at the end, because you can have a subtle mushroom cloud or, you know, bleeding that regular angiography doesn't detect. So for the completion angio, I always
Do DSA.
Visual substruction.
Yeah.
So when we do, great point. When we do for the TAVRs, we always do DSA angiography. I still get ultrasound guided access, but for the completion angiography, do DSA. In this particular lab, I had a small eye with no DSA, so.
The ultrasound is
That's the
probably
pictures.
adequate. I mean, you can do it all the time for pacemakers, and it's just, you know, you can see everything you're going after with
Yep.
the lung. So I think the DSA definitely works, but it, you know, three-dimensionally, you can see it better. with
I
ultrasound.
feel like I can see the branches better, too. I have some idea where I'm actually accessing the artery to some degree, but.
I think that's a great case showing how drip planning actually is helpful. You do the CTA, see the size of the vessel. I mean, during that episode of no reflow, if you didn't have your impella, this could be a disaster.
It would have been, yes.
And you would have presented.
Yes, exactly. That's
Similar
true.
thing, I mean, if you have low EF patient, multivessel disease, you want a rota, you want an atherectomy, you always should think of no reflow and having support, as difficult as it could be. I think is the way to go. And you could get lucky one time or two times, but it's going to catch you.
Good planning. What size would you cut off? Would you cut off for that impella?
So what, probably about 5. Yeah, 5 and a half. That's what we've generally been using. If there's a lima,
Or CP.
CP, yeah. When there's a lima there, I like at least a millimeter or a millimeter and a half or 2 millimeters greater than the sheath size. But,
Thank you.
all right, thank you.
So we'll try to miss Dr. Godella again here. Cross your fingers. Yeah. There you are.
Thank you. Hello again. Hopefully this works. Not sure what happened before. So I'm going to present a challenging case of orbital atherectomy and hemodynamic support with impella in an elderly woman patient that was done at our institution earlier this year. Case presentation, she is an 85-year-old female with prior history of CTO of the left circumflex and CTO of the mid-RCA with collateral flow from LAD, which was diagnosed in 2011, that has been managed until she presented with a progressive dyspnea and exertion, NYHA class 3 symptoms with CCS3 angina equivalent symptoms. The echocardiogram showed her EF was preserved, pulmonary artery pressure was 51, and no major valvular abnormalities. Her past medical history pertinent for type 2 diabetes mellitus with diabetic neuropathy, hypertension, hyperlipidemia, stage 3 chronic kidney disease, and mild COPD. Her medications were Plavix, simvastatin, amlodipine, metoprolol, spironolactone, insulin, metformin, and some of these medications were added when she presented to our clinic with her symptoms. Her pertinent laboratory findings were hemoglobin 14.0, platelets 311, creatinine 0.85, and her creatinine clearance EGFR 64. So we did have an extensive discussion with the patient and family because we already know the information that she has prior severe two-vessel disease. So we, after discussing with the patient, we proceeded directly for the coronary angiogram with an intention that she might need an intervention. So we were not able to get the radial access because her Allen's test was abnormal, so we had to proceed with right femoral access. So here, as you may see, the RAO caudal view, she has circumflex CTO with collateral circulation and the heavily calcified LAD. And then on the LAO cranial view, also severely calcified LAD and LCX CTO with collateral circulation. And then the right-sided with showing ostial 90% disease and mid to distal CTO with collateral circulation. We thought she might, as prior discussion with the patient, she might need an intervention. So we did do right iliac angiography in anticipation of hemodynamic support with Impella. So the right iliac angiography was showing severely calcified iliac arteries and then moderate disease. So the patient was referred to the cardiac surgeon, given her 3-vessel disease, and they thought that the patient was too high risk for CABG. And again, we had like a lengthy discussion with the patient whether she would be managed medically or proceeded with PCI. The patient opted to proceed for the percutaneous coronary intervention. So in summary, this is an 85-year-old female with prior severe 2-vessel disease, now with severe 3-vessel coronary artery disease involving LAD and severely calcified coronaries, is now severely symptomatic despite optimal medical management. Comes to the PCI strategy, we thought that we would fix the ostial RCA PCI first and then approach the left-sided obstructive disease with Impella support, as the patient has global ischemia, very complex anatomy, advanced age, and severely calcified coronaries and stage 3 chronic kidney disease. The patient was brought back after 2 weeks, and we did the right-sided ostial RCA PCI, right femoral approach, and the patient, we used 6 French AL 0.75 and 5.5 French guideliner as well, and BMW wire, and the patient was pre-dilated with 2.515, and she had Xine's 3018 stent was placed, and the result was good. And then the PCI strategy for left anterior descending artery. So unfortunately, the patient developed right groin hematoma, which was very diffuse. And in addition to her the iliac artery heavily calcified, we thought that the right femoral access is not optimal for hemodynamic support, which required for 14 French sheath. So we thought she need alternative access options. So we decided to proceed with the left axillary access for the hemodynamic support with Impella CP. And we used left femoral access for the interventional equipment delivery. So initial selective left subclavian angiogram, as per the prior presenter showed, we did not do the CTA of the subclavian. So initial left subclavian angiogram, 5 French left femoral access, JR4 showing the patent subclavian artery. And we used the initial 5 French followed by 6 French just below the inferior glenoid cavity, and then dilated to allow 8 French. And at this time, we used 2 pre-close 2 o'clock position, which did not tighten. And then this is followed by the 14 French Impella sheath. And then this is followed by the Impella placement in the left-sided subclavian axis. We thought the left axis is more feasible because it's more in trajectory with the heart and also less risk of stroke compared to the right-sided axis. And then for the intervention, given her heavily calcified coronary arteries, we decided to use orbital atherectomy, which we use exclusively in our institution 95% of the times for the heavily calcified arteries. We used through the left femoral axis 6 French EBU 4.0, and then we also used 5.5 guideliner as well. BMW wire, which was exchanged with Viper wire for CSI. And on the proximal LAD, the patient had 3 to 4 runs of CSI, and then the distal, the patient had like 2 to 3 runs, which is followed by the pre-dilatation with balloon in the proximal, in the distal initially 2.25, 25, 14 atmosphere at 10 seconds, and then in the proximally 2.25, 25, 10 seconds proximal dilatation. And then we implanted in the distal 2.5, 32 Boston Scientific 24 atmosphere for 15 seconds, and the proximal 3028, 26, 10 seconds. And the final result post PCI, the result looks good. Her LAD is opened much better than her pre-angiogram. So the technique we used was the dry closure technique that was described before. So we used the glide wire through the left femoral axis, and then over that we used 8 by 40 Evercross balloon to occlude the proximal left subclavian artery so that we can safely remove the impella sheath. So then the impella sheath was removed while the balloon was occluded the proximal subclavian artery, and then after the impella sheath was removed, 2 pre-closed devices which were used earlier were tightened to close the access site. And the patient had no vascular access site complication post-procedure and normal left radial pulse. And there was a little bit of kink, as you may see here, which we thought not significant given the patient had good left radial pulse and brachial pulse. We thought it's acceptable. And the patient was seen in the clinic 1 month after the procedure, and her shortness of breath was improved significantly, no angina, and her exercise capacity was also improved significantly, and her left circumflex CTO was managed medically.